So welcome to this PCR webinar on how should we treat low-risk patients with aortic stenosis. With TAVI being now a reasonable and validated option for low-risk patients, it's the role of the heart teams to be able to have a critical interpretation of the low-risk trials in order to individualize the treatment of each particular patient, and also and finally to discuss which low-risk patients should be offered still surgery. And these are the objectives we would like to cover during this session this afternoon. And of course, in order to discuss that, it's mandatory to have a discussion with colleagues, cardiac surgeons. That's why I'm happy to introduce my two friends and colleagues, Professor Sabine Bleisiefer from Bad Oeynhausen in Germany, who is cardiac surgeon, but strongly involved in transcatheter heart valve treatment. Welcome, Sabine.
Hello.
And also Professor Thomas Modine from Bordeaux, France. Also cardiac surgeon, but with a strong involvement in transcatheter heart valve therapy. Welcome, Thomas.
Hello.
So maybe just before to start our session, I would just like to remind our colleagues who are connected that you are warmly invited and encouraged to submit all your questions through the chats throughout all this session, and of course, we'll be happy, if appropriate, to answer those questions and to answer to your comments. I think, Thomas, Sabine, we can start with a case example that will help us to discuss this topic about heart team discussion and management of patients at low risk with aortic stenosis. So let's have a look at this lady. It's a patient we had to treat in Toulouse few weeks ago. 79 years old, severe aortic stenosis, no ambiguity about the severity assessed by echo, as you see, and symptomatic with an aortic class 2 shortness of breath. It's a lady who lives independently at home with her husband, with an absolute no cognitive impairment, no frailty, and she just have a past medical history of hypertension and arthrosis. So she had, as we do in such a setting, a conventional pre-op assessment. These are the main results from a biological standpoint: no renal impairment, no anemia, coronary angiogram, no significant tight coronary artery stenosis that would require any revascularization. ECG, sinus rhythm, narrow QRS, no AV conduction, high degree disturbances. The CT, it's part at the heart team discussion step. It's part of the comprehensive assessment we do. You see on the left of the image a quite standard anatomy, no anticipated issue in case of potential TAVI. Aortic annulus is quite standard also regarding the measurements, 23 millimeter, according to different and various measurements we do. And to summarize the CT assessments, no need to put all the details, but let's say a global evaluation of the aortic roots showing no risk of coronary obstruction, a free leaflet aortic valve morphology, and only moderate calcium. So what I would summarize is as a favorable anatomy for transfemoral TAVI with any commercially available device. So maybe if we now come to the heart team discussion, what is the core of what we want to comment and discuss this afternoon, Sabine, I would start with a question to you, because when we talk about low-risk patient, there is sometimes a confusion that is made between age, life expectancy, and low risk for a patient. Okay, what can you say about that?
So when we look at her age and her life expectancy, I looked that up in the German statistics, and a 79-year-old woman still has a life expectancy of 10 years, in Germany at least. So that means what we need is to offer her therapy that has symptom relief and durability across the 10 or more years that she still has to expect.
Yeah, thank you very much. And would you say, of course, it can be obvious, but needs maybe to be clarified. Do you agree that, of course, we have to separate the risk assessments and the age and life expectancy assessments as some consequences regarding the choice of therapy we will offer?
That's somewhat true, but I think there is an upper age where everybody would agree both TAVI is the better treatment, but I think in this patient, 79-year-old, in a really good shape as it seems and really low risk, both treatments might be a good option for her, and therefore I also strongly support to include such patients in randomized trials also, such as the Dedicate trial. So if she is eligible for both treatments and there is the availability of such a study, I would strongly recommend to include these patients in such studies.
Okay, thank you very much. Very clear. Thomas, a few words about frailty and frailty assessment impact in this context of low-risk patients. What are your thoughts about that?
So let's make it clear. This question is not related to the case you presented and that we have been discussing with Sabine earlier. So, of course, whenever you come to talk about age, you have to look also at the clinical presentation of the patient himself. And with that perspective, frailty is one of the factors that you have to look at. So there is a clear difference between this lady that you have been presenting, who's 79 years old, and a young patient with some other comorbidities that could interfere with his life expectancy. And in that case, even if he's younger, let's say below 65 even, if there is something that could interfere with his long life, I think TAVI is an option to consider strongly.
Okay, thank you very much, Thomas. One other topic I would like to discuss with you, that is part of our everyday, I would say, heart team discussion, is the impact of comorbidities. So, of course, again, in this context of low risk discussion, I no need to talk about comorbidities impact in higher risk patients. But what I think is sometimes we see some low risk patient coming and asking for a TAVI because having comorbidities like diffuse arthrosis with diffuse pain when being lying in bed for a long time or things like that. You, as cardiac surgeon, maybe Thomas, is it something that is put into your algorithm for the choice, or you don't think it's something that is strong enough to orient the decision?
You know, Nicolas, this is again a very good question, and I mean the chance that we have, like Sabine here, being surgeons but also involved in percutaneous treatment, gives us this open view. So let me take this example of the patient you've been talking about. This is, I would say, a patient who could be candidate for both therapies, surgery and TAVI. He has a severe pain for which he needs to take analgesic treatments on a long term, but also usually these patients have corticosteroid therapy that could lead to other complications which he might not have today. It may appear tomorrow. I'm talking about diabetes, renal failure, hypertension, whatever. So this is, again, a very important thing to take into consideration, the clinical factors, that you are calling here comorbidities. I mean, it's very important to us to apply the best practices and what science is teaching us, but it's also very important to keep in mind that we are treating a patient, and his quality of life today and tomorrow is also very important. I'm really insisting on today and tomorrow. But in the setting of a patient who is suffering and he has a severe aortic stenosis, and we don't want to add any additional pain and heavy treatment, I think TAVI also is an option to consider.
Thank you very much, Thomas. Sabine, I purposely in the presentation I made about this case example to generate the discussion about how, as a heart team, we discuss patients. I purposely put the CT scan assessment because this is what we do. We assess the anatomy at the CT scan for any patient. Any comments on that?
So I think that's very smart to do that. The CT gives so many useful and important informations to assess the risk and the anatomy, how suitable it is for one or the other procedure. For example, calcium spots in the ascending aorta, which are not visible by other imaging techniques, but may pose a higher stroke risk if you do surgery and clamp the aorta. Or if you assess the anatomy of the aortic root and you see a heavily calcified bicuspid valve with a lot of LVOT calcium, very unevenly distributed. So you know there is a high risk for PVL and maybe an increased risk for pacemaker. So this might not be a good candidate for TAVI. So the CT gives so much important information that I also would like to promote this for every patient, although we are not yet at the point at my center to do that in all patients. But yeah, I fully agree that this is one of the most important tools to discuss in the heart team when we see the CT.
And Thomas, last word about this heart team discussion. Thinking about our current everyday practice, I realize that less and less we rely on the risk score, surgical risk scores calculation to influence our decision. What is your opinion on that?
You know, Nicola, these scores are, I mean, we are lucky to have them because we needed a baseline when we started doing TAVI, and we needed an element of comparison between the two techniques. But of course, if we look at them now that the safety and efficacy and even midterm and coming to longer term TAVI outcomes are there, we have to acknowledge that they are not of help anymore. And there we have to think about risk scores evaluation differently. So to be honest with you, I mean, in low risk patients, when everybody comes to be below 4 STS score, for example, I mean, I don't know which kind of information we can get from these risk scores. And this is why I really insist on the fact that a discussion, rational and open discussion between surgeons and cardiologists should be open and in order to orientate these patients. So for me, going to low-risk patients and younger patients is definitely taking us away from risk score efficacy in order to guide us in our practice. This is for sure. I mean, let me take the example of your lady. You know, let me give, if you imagine you calculating the risk score of a patient candidate for aortic valve replacement, TAVI or not TAVI. If they are below 70 years old, you can try it. They all end up with a score of 0.88 Euro score 2. They all end up with the same score. But we know that if you have to look internally at each patient, there may be some differences which are not captured by the scores that are worth looking at. For example, your example of lady, I mean, Sabine is right. I think even in France, the expectancy of life of a perfect shaped patient of 79 years old could be 10 years. However, this lady, if you look at her CT scan, for example, and you know that you're gonna be putting only a 19 or a 21 surgical valve, or if you want to do a bigger one, put a bigger one, you have to enlarge. It's not the same story. So maybe in that case, TAVI is a good option also, but this has to be discussed in the confine of a heart team. And again, this will be, for me, superior to risk scores.
Now, thank you very much, Thomas. Sabine, you had one small comment about that.
Exactly. I would like to say that the risk scores still are very useful in the high-risk patients, because if we have a high score, we know this is a TAVI patient. But in the lower risk group, they are less useful. I would agree.
Yeah, thank you very much. Very, very important and useful comment. So let's summarize what we have discussed. And what we could say maybe is that our current modern heart team discussion uses, for all risk patients, of course, rather than surgical risk score assessment, focuses on life expectancy versus age balance, comorbidities or frailty, potentially impairing quality of life despite aortic stenosis treatments, and that those low-risk patients deserves anatomical assessments of what we could call TAVI procedural risk by a comprehensive CT scan evaluation prior to any treatment choice, because this could orient good candidates for TAVI, but also could orient bad anatomical candidates for TAVI to surgery for sure.
Okay, so I would like to introduce a lecture from Thomas as our next topic with his critical review on the low-risk trials of TAVI. Thomas.
Thank you, Sabine. Nicola, dear colleagues. So, I mean, TAVI made a lot of progress, which led to the change of the latest guidelines that Sabine will be talking about later on. And it was a long journey that led to one of the most famous publication, I would say, with the biggest impact factor, the New York Times last year, where the title was the following: 10 of thousands of hearts will be not needed to be opened anymore. So it gives you the impact of this evolution and progress of therapy in our practice today. And there are two ways to look at real data and real science, I would say. I mean, the glass full empty or half empty. There is, I would say, I mean, the title of my presentation is a critical review of low-risk literature. I don't want to be the guy who look at the glass half empty, but I want to just to attract your attention to that we are looking only at the visible part of the iceberg. And as doctors, and again, as believers in heart team, I think it's our duty and responsibility to show and share and increase awareness about what could be the best practices based on really what these studies content were addressing. So there are, of course, from surgeons' point of view, some doubts, some limitations, and some concerns, because they have a major conflict of interest, is that they are not TAVI users. But I mean, let's look at them and listen to them. And from that perspective, major limitations are age. We have been debating about this. There are a clear difference between score risks and age. The screening is very important. We'll be talking about that, and concomitant procedures, because this is real life. So let's look at the following. If you have to really acknowledge and consider that only 1.3% of the patients in Evolute low-risk trial were below 60 years old. So again, this is just really to highlight that if low risk was definitely validated for Evolute R in this category of patients, it doesn't mean that patients below 60 years old have been validated with this valve. If you look at the partner 3, for example, only 7% of the patients were below 65 years. So at least from this perspective, there is a threshold that we have to keep in mind whenever a patient is referred to you. There is another major point to discuss and to highlight is how the screening was done and which patients were considered eligible for an Evolute, a low-risk trial or partner 3 trial. So if you look at the partner 3 trial, 34, this is a huge number, 34% of the patients were deemed inappropriate for this study. And this is why we have to look at what does it mean? Because 30%, that means if we want to translate this to our practice, out of 3 patients, 1 is not a good candidate for TAVI, although he's at low risk. So we have to know which one is that one. And if you look at the Evolute low-risk trial, it was 14.8% of these patients. So it's also a consistent number that we have to understand why. This is a very important study that have been published recently by Rodez Cabot-team. And it's very important. It shows that in this, the experience of this team, patients who are referred for surgery to treat aortic stenosis, at least 50% of 50% of the cases, 50% of the patients were not ideally captured by the factors of studies like low-risk Evolute or partner 3 trials, which means that in real life, and this is what we want to deal with every day, there are some missing parts that make all patients not necessarily good candidates for TAVI, and among these factors, non-tricuspid valves, so bicuspid is one of the limitations, concomitant severe coronary artery disease, I think Nicolas will be talking about this later, additional mitral or tricuspid surgery, this is a very, very important thing, and some other factors which are really detailed in this study, which is of great value. Concomitant procedures is not rare. If you look at, when it comes to compare partner 3 trial or Evolute low-risk trial, you will see that there were 8% concomitant procedures versus 35 in the surgical arm. And I don't think that the surgeons were happy and were pleased to do additional procedures, which they didn't want to do initially. It's just when you open the heart and you see that there's something wrong, you have to do it and you have to deal with it. And this may be unfavoring the final outcome. So we have to keep it in mind also and see which one is the best therapy. And the same for Evolute low-risk trial, 7% versus 26% additional or concomitant procedures in the surgical arm. Surgeons have some concerns because they consider that SAVR could be doing better in some cases. Paravalvular leak. I mean, we know as TAVI implanters also that this paravalvular leak is almost a tackled problem now with a careful and wise selection. CT scan is part of it, and the distribution of the calcium, for example. I think if you have a good practice and good expertise, paravalvular leak is not a big issue anymore. We know that. Pacemaker is a very important one, but this also could be more or less oriented by the best practices. We could talk about cusp overlap. Patient prosthesis mismatch. This is something we have been ignoring. We have been ignoring in high risk and intermediate risk, but in low risk patients with long-term expectancy of life, this has been shown tremendously in surgical publications. I will show you that this could compromise outcomes in the future. Thrombosis, we have a lot of negative outcomes or alerting outcomes that we have really to look at and evaluate after TAVR. So we have to really to evaluate this and see how to deal with it. We used to know this kind of problems with surgery, and we found solutions for that. So maybe it's going to be the case for TAVI. We have to look at it. Bicuspid, of course, and long-term durability. This is something that we'll be discussing. So this is what I've been talking about paravalvular leak. Although the percentage is really decreasing by careful selection, we still have some patients with mild paravalvular leak, for example, which we don't have the surgery. We have only trace. Does mild paravalvular leak have an impact in the future? We never know. We have to evaluate this. And this is also because we know that paravalvular leak could have a high impact on mortality, and this is something we want to avoid in low-risk patients. Pacemaker, from partner 3, we have less pacemaker rate implant, but we have a higher rate of a left bundle branch block, and this also have been shown to be impacting the long-term survival. So this is something also we have to evaluate. And I think our practice improvement, again, we can use cusp overlap with self-balloon expandable valves, and this could decrease this number. We're doing this on our daily practice. And the same thing for Evolute low-risk trial. I mean, there are some recent reports reporting that the use of cusp overlap helps implanting a bit higher, and by implanting a bit higher, it will be very good. So we also know that conduction abnormalities increase the risk of mortality due to heart failure. Patient prosthesis mismatch, I talk about it, and this is something that we cannot ignore. Bicuspid is definitely associated, for example, with a higher mismatch rate. So this is something also we have to acknowledge, because when going to younger patients, as Sabine had been talking about, we have a higher rate of mismatch. So this is something we have to look at carefully. I know many of our colleagues are talking about Notion 2 at 8 years, but be careful, because what we can learn from surgical point of view is that the break point appears more or less around 10 years. So you can see that in all categories of patients, you can have a beautiful follow-up up to 10 years, and after 10 years, there's a break point. So we have to be very careful before going to younger patients based on what we know from surgery. So this is what I wanted to tell you about my critical review to low-risk trials. Of course, it's validated, but we have to keep the eyes open, and we be very critical with what we know and what we don't know yet.
Thank you very much. Thank you very much, Thomas. And I think it's always necessary and useful to have a critical discussion about those low-risk trials. You mentioned several points, but I would like to come back to some of them. Because as you mentioned, the low-risk trials could be falsely interpreted as the possibility to extrapolate the indication of TAVI for any low-risk patient. Of course, it doesn't have to be done, and in specific anatomical subsets particularly. So Sabine, in very few words, I think the bicuspid anatomy group deserves some important comments.
Yeah, first of all, this group was excluded in the low-risk trials, and there are data showing us that in the age group of 50 to 80 among surgical populations, there are up to 50% bicuspid valves. So it is a large group of patients in the younger patient population. For surgery, this does not make such a big difference, because we cut out the valve and insert a surgical valve into it. And for TAVI, it makes a difference, because unevenly distributed calcium may pose a PVL risk, sizing may be a problem, and size limitations. And what I want to say is that, sorry, I forgot what I wanted to point out. Bicuspid is not bicuspid. That's very important. So there are bicuspid valves and bicuspid valves. And when we look at the data after TAVI, we see there is not such a major problem of PVLs. And this tells me the patients are very well selected when we decide to do a TAVI in a bicuspid valve anatomy. So
okay, thank you.
Another point,
yeah, sorry.
One other point, there are meta-analysis demonstrating us that there are still some trouble with the bicuspid populations. There is higher stroke risk and higher procedural complications, such as conversions to surgery. So although TAVI is really feasible, because we have a lot of experience now in bicuspid patients, we should not forget there are some challenges.
Yeah, thank you. Very clear. So what we could summarize in maybe a even more cautious anatomical assessment of those patients, and of course, for sure, for less than 80 years old, low-risk patients, very low and almost no arguments to favor transcatheter treatment. You agree with that?
Yes, I agree. So we should, in those patients, we have to balance the risk versus the probability of a good outcome with one or the other procedure.
Nicolas,
yes,
can I add? Yeah, one quick comment. I think there's also some misleading interpretation of the registries that we have been leading in Toulouse, for example, with us, and outside of France also. There is I think there's an overestimation of the number of bicuspid patients we are treating, which is due to what we call false bicuspidation. And surprisingly, in these registries, we encounter more bicuspid patients treated with TAVI than those that we treat with surgery on daily basis. So, and based on this, we consider that bicuspid could be treated easily with TAVR, but it's not. The challenge of TAVR is bicuspid is the calcium amount, which is much bigger, higher than tricuspid, and also the fusion of the raphes, which are much more fibrotic. So this is a complete different story.
Thank you very much for this additional comment, Thomas. Sabine, again, a few words about patients being sometimes with bicuspid associated aortopathy. So, of course, if there is an obvious indication for surgery, no need to discuss that very long. But maybe one precise question, is the evolution of this associated aortopathy strongly related to the evolution of the valvular aortic disease? And in other words, if you treat the aortic valve disease, can you expect that the aortopathy will be stable afterwards?
I think this is still not clear. So there are two possibilities: that it is a hemodynamic mechanism of the development of the aneurysm, or it might be a degenerative aortopathy. That means that would be an ongoing process also after aortic valve replacement or TAVI insertion. So, and we know patients with a bicuspid valve have a 25% risk among time to develop an aneurysm or to have an indication for surgery. So again, it will be a balanced discussion in the heart team. I would say if you have an 85-year-old patient with a bicuspid valve and an aneurysm, you might take the risk of a progress of this aneurysm and give him a TAVI. But in maybe a younger patient with an unfavorable anatomy for TAVI and a dilated aorta, it is clear that surgery would be the better option for this patient. But I think it's unpredictable if the aortopathy will go on after aortic valve replacement or not.
Okay, thank you. Thomas, we might have, and we often have the association to a severe aortic stenosis in a less than 80-year-old patient, low-risk candidates, association between aortic stenosis and complex coronary artery disease, especially in diabetic patients. Is this for you an argument that can favor a surgical treatment rather than a percutaneous one?
Yeah, and Nicolas, I think, as you know, there is no consistent studies, I would say, showing the superiority of this or that approach. I think the easiest and the most rational way to do it, and this subject has been how do you say, animated a lot of sessions during Euro PCR and PCR London Valve, and we need to find a consensus on that. I think this is very important. So if a patient is a good candidate for PCI, he can go for a PCI and a TAVI. If a patient is a better candidate for surgery because, for example, a higher syntax score, or because a lesion is touching the bifurcation of the LAD or any bifurcation on the vessels, I think this is should be also a surgical case. But I think also there is a huge place for hybrid patients for in this setting of disease, aortic stenosis plus coronary artery disease. But this is much more realistic, I think, in high-risk patients than in low-risk patients. I think in low-risk patients, a good surgery with a good Lima 2 LAD and aortic valve replacement keep all the doors open for any future therapy. And this is the way we try to keep on evaluating and treating our patients.
Thank you, Thomas. And maybe one last point or subset of patients I would like to focus on are the ones at risk of peri-procedural coronary occlusion in case of TAVI. You mentioned, Thomas, and I think it's clear for everyone that the TAVI low-risk trials only included patients with favorable anatomy for TAVI. It means that they had favorable anatomy regarding the peripheral arteries, not that one, but also that they had favorable anatomy regarding the aortic root anatomy. And if you have example in the previous slide that you will see, if you had the example of very low coronary takeoff very low and very narrow aortic sinus. Of course, we have learned with our high-risk TAVI experience that we can have some technical solutions to solve that. But I consider as physician that it's not safe and it's not fair to do such bailout or stenting complex procedures in low-risk patients that could benefit from surgery.
Yeah, so Nicola, this is also, it's not rare to encounter this type of patients. And as I always say, if you put the patient first, I think you have to consider what's going to happen immediately around the procedure, during the procedure, but also around, but also what will happen later on. And I think from this perspective, if you take this cutoff of 10 millimeter, I think whatever the type of the device you are using, it will not make a PCI in the future very easy. So again, I would strongly recommend in that case to go for surgery for coronary artery disease in addition to aortic valve replacement, or simply an aortic replacement if the coronaries are normal. Some patients could be referred to you because you know how to deal with this very well, but sometimes they have acute coronary syndrome during the night, and they are referred to centers where the cardiologists don't know really and don't have the experience to tackle this problem. So what would you do in that case? So again, think not only about today, think also about tomorrow for the goodness of the patient.
Thank you, Thomas. Before to go to Sabine next talk, maybe two short answers to two questions coming from colleagues from the audience. This one for you, Sabine. How do you deliver and explain the heart team discussion to the patients? Who delivers this synthesis? Is it the cardiac surgeon? Is it the cardiologist? And will the patient choice, or does the patient choice can influence your final decision?
So I think the best always is if the cardiologist and the cardiac surgeon go to the patient together to explain all factors of his individual anatomy and of his individual risk for each or the other procedure. I think one of the main problems is that many patients are not well informed. They just come to a hospital and say, I would like to have a TAVI, but they don't know what their specific risk for TAVI or for surgery is. And this is our task to explain to the patient and to inform the patient of all aspects. And therefore also the CT is very important. If a patient has a strong wish for a procedure we do not support, we would even recommend him to discuss at another center. So I think it's not all about patient wish. The patient has to be well informed, and if he is well informed, he might contribute to this decision and discussion. But if he is not well informed, it's sometimes very difficult. But the best thing is to discuss with the patient together in a room with the cardiologist, cardiac surgeon, and the patient. We aim for that in many patients.
Thank you very much for sharing your experience. Thomas, in a few words, another question. What is your opinion and what is your choice of TAVI prosthesis with regard to coronary access in low-risk patients with higher life expectancy?
This is a good question. Listen, it's à la carte. I don't have a predetermined choice. I really look at everything. I look at the anatomy. I look at the other risk factors, because, I mean, you cannot prioritize a risk and say this risk is worth being taken and not the other. To be honest, it's very reductive to limit this. I mean, I'm not escaping the question, but it's multifactorial. So I have no preference for any device. I put all the factors, multivariable factors, and I make my multivariable analysis, case by case.
Thank you very much. Sabine, I think it's time now to listen to you about your main informations that we can extract from the recent North American guidelines on aortic stenosis treatment.
Thank you. Yes, this was a challenge to extract some data from 150 pages packed full of with information. So these are the citations. The guidelines were available this year. They start with 10 take-home messages, and I would like to highlight the take-home message number 4, which is about the heart team, and recommends that all patients undergoing any intervention for valvular heart disease should be evaluated by a multidisciplinary team, which I find is very important because the heart team should not only confirm the indication for a transcatheter procedure, but should evaluate all patients with valvular heart disease. So, and then the heart team has first to assess the risk of the patient, and that should be done by risk scores. And there is a clear definition of what is a low-risk patient in these guidelines. So the first thing is you have to calculate a score, and then if you have a low score, risk calculated by score, then you have to have no frailty. The patient has to have no cardiac or other major organ system compromise, and it is all listed here: cardiac, pulmonary, liver, and so on. And the fourth factor is that there should be no procedure-specific impediments like porcelain aorta. So there are 4 factors that define a low-risk patient. But it is also clear that there are different factors that influence the risk for surgery or for TAVI, and this is also highlighted. For example, for SAVR, you have to take into account ascending aortic calcifications. For TAVI, other factors increase the risk, such as low-lying coronary arteries, as we already discussed. So, and if the heart team now has identified a low-risk patient, it comes to the decision TAVI or SAVR. And there we have 3 class 1A recommendations for 3 age groups. And there is a bit of a surprise, I think, when we look at these age groups. First of all, above the age of 80, all patients are recommended to have a TAVI, which I would also support. Below the age of 65, we should rather go for surgical aortic valve replacement. This threshold of 65 was a surprise to me somehow, because it is not really easy to understand how it is supported by the low-risk trial data. And in between these age groups, 65 to 80, the multidisciplinary heart team has to decide which is the best procedure. And as we already discussed, we should not take into account only risk score or only factors, but the whole picture of a patient. And there is a large table in the guidelines. Everybody can read them. I just want to highlight some points out of this where we should favor SAVR or TAVI. Bicuspid aortic valves are more in the favor of surgical aortic valve replacement. Then from prosthetic valve preference, there is the topic of patient prosthesis mismatch, and I think there is a balanced discussion on that. In the European guidelines, we have only risk of patient prosthesis mismatch should rather go for SAVR, should favor TAVI, transcatheter treatment, but in this guidelines it says also, okay, if there is a risk for patient prosthesis mismatch, you could also consider surgical procedures such as root enlargement. So patient prosthesis mismatch can favor both sides depending on what the plan for the surgery or TAVI is. And finally, there are some discussions about patient preferences, and there we have the topic of uncertainty. So uncertainty of valve durability may feel a patient better to have surgical replacement because we feel we have more certainty about the durability here. And what also can be discussed is the risk of pacemaker, because many patients say, oh, I really fear the risk of a pacemaker. And maybe for some individual patients, this might underline the choice for a surgical procedure because the risk is lower. And if I
So we lost Sabine, we lost the sound.
Can you hear me?
Yes, it's coming.
I'm so sorry. So three final facts. What are the essentials from the ACCHA guidelines? TAVI for all in patients above 80, heart team discussions for all patients with valvular heart disease, and it is always a multifactorial decision, especially in those low-risk patients who can undergo both procedures. It's not only risk scores, it's not only age or life expectancy, and it's not only anatomical characteristics, it's the whole picture.
Thank you very much, Sabine. And I think we can stay on that summary slide because you perfectly summarize, I think, what is important and what is necessary to extract. I have one question coming from one of our colleagues listening to us currently about this issue of age that we have in this new version of a guideline. So it's quite clear, obvious, and I think well admitted by everybody that above 80 years old, it's now obvious that in case of favorable anatomy, whatever the risk, TAVI should be the preferred option. But you partially commented on that. What about this lower cutoff of 65? How can we justify that, and how is it supported by the evidences we have so far?
So to me, it seems not really supported by data. It's somewhat arbitrary, I think. So the mean age of the low-risk trial patients was 73 and 74 years. So I would say most of the patients were above the age of 70. So it's just a feeling, I cannot really support it, but to my feeling, the age of 70 would be a much better threshold if we rely on the data we now have.
And we've seen it.
Mean age of the low-risk trials was 73 and 74, right?
Exactly.
Yeah, and we've seen it in the critical review of the literature that the majority of patients were above 65 years old. So this is very important. I think this is where the cutoff comes from. So not below 65.
Okay, thank you. And I think this global reflection and discussion leads us to the next question and issue we have to deal with as physicians in the heart team. Is how to deal with lifelong management of those young patients with long life expectancy suffering from aortic stenosis, and in other words, anticipate and be prepared for the re-intervention those patients will need. So regarding this consideration and this issue, of course, Thomas said some words about structural valve deterioration. Sabine, that is a burning question and a burning issue when it comes to compare TAVI and surgery. What, as cardiac surgeon, but also offering TAVI to your patient, and considering a young patient, is this issue of SVD, potential SVD of a transcatheter valve, something that would lead you not to offer TAVI as the first intervention?
That's really a very difficult question because indeed it is a shame that we don't have better data on that. So we are implanting bioprosthetic valves for decades now, but the data is not very good, I would say. So there are things we know. We know that after 10 years, surgical prostheses start to degenerate, and after 20 years, around 50% are degenerated. And there is also an age dependency of this phenomenon, and below the age of 60, the process is much faster. We don't have, and we see that especially porcine valves have a very good longer-term durability, but the everyday practices that we prefer pericardial valves because they have the better hemodynamics. So there is also a lot of discussion in that. And we do not know many things. We do not know how do the valves compare to each other. We don't have comparative studies. And there are also a lot of newer valve types that are implanted quite commonly, such as the trifecta valve, for example, where we don't have longer-term data. So there is a lot of conflicting data, and there are a lot of discussion points. And in the end, we need more data on durability also for the surgical valves.
Nicolas,
yeah, Thomas, I was about to ask you a question coming from one of our colleagues related to that topic. In your opinion, what is the best way to answer if a low-risk patient is not so favorable to surgery, and asks you as a surgeon about how durable the TAVI valves are as compared to surgical valves? How do you answer to those questions?
I will answer that I do not know exactly. I would recommend him to be included into a randomized trial. I will tell him that that we know that surgical valves last about 10 to 15 years, and that we believe that TAVI valves will be around the same because they are also biological valves.
Yeah,
that's what I answer.
And I will add to this, which is I really completely agree with. We don't, except Notion, there is no randomized controlled trial that showed a durability superior to 8 years. If I take the study from Lars Sundergaard, the number of patients that have been followed at 8 years is less than 50 patients. Okay? And the other factor, important factor, is that the choice of the surgical valve has been left to the discretion of the surgeon. And many of valves with a very low durability has been used. So again, if you want to be honest with the patient, you have to tell him the truth. And we don't know. And the other thing, and this will influence also the choice of the valve you're going to use, is what are the possibilities and how easy will be the surgery if it comes to explant a TAVI. This is a big question mark. And you don't want to transfer an aortic valve replacement into a Bentall surgery with the coronary suturing, which adds some risk to the risk. So we have to be very careful.
Yeah, thank you. And it comes to another question around this topic about choice of valve for the first intervention of long life expectancy, low-risk patients. Just imagine the hypothesis of TAVI choice. And it's a question, again, coming from one of our colleagues. Would you consider that based on the data we have, it is mandatory to implant one or the other valve that has been validated by one of the two low-risk trials? Or you would consider that it's a kind of a class effect and then would offer any commercially available TAVI device?
So, absolutely not. Listen, today, surgeons have to apply the best practices. And if you want to do a surgery on a patient, from an ethical point of view, you have to use the valve with the longest durability. Otherwise, go for a TAVI. I see no reason for why you use a surgical valve with no durability validated. So for TAVI, it's going to be the same. Today, there are only two valves which have been validated for low-risk patients, which are Evolute valve and S3 valve. And this is the only thing we can talk about today.
Okay, thank you. Very, very clear, Thomas. Thomas, another question for you, coming in this discussion about being prepared for the reintervention. Is which procedure first? And maybe we can see one slide to support your answer. If we think about treating those patients with long life expectancy, then which procedure should we consider first?
Yeah. So this slide does not come from me. It comes from Carlos Ruiz and colleagues, and it has been published in a Spanish review. But I see it; it's a very clear one. So you can see it here. This is a real question, and I just want to highlight the importance of surgeons being involved in TAVI procedures in order to understand the properties of the valves and know how to explant them. So we know how to implant, but they have to know also how to explant. And you see here, depending on the age of the patient, you could more or less put the TAVI first, and then surgery second, and then take the surgery valve out, and then put the new one and do a valve, a TAVI in the surgical valve. If the patient, I think reasonably, if the patient is below 65 years old, you have to consider doing also ROS procedure. But this is more for patients below 50 years old. Otherwise, I think there are some other factors, like if the patient is capable of taking for long life oral anticoagulants, and this is something to which he has to participate. If the patient has a practice, and I mean, a way of practicing that puts him at a risk of bleeding if he is under oral anticoagulants or not. And then if you are putting a TAVI or a surgical valve in a small anatomy or not. So again, you see it's not an easy diagram, but it is going to be definitely decided by heart team. And to this, I will add the choice of the patient in this setting. It's very important, or at least the discussion with him.
Thank you very much, Thomas. And I think one last topic we could discuss, and that is, I think, very important. Again, thinking about reintervention in this setting of long life expectancy patients, is all those issues related to TAVI or valving, aortic valving valve procedural techniques. And I think two of them are of importance. First, the risk of mismatch, of severe residual stenosis, and you have on the left of your screen the small inner diameter of a degenerated 23S3 and below degenerated surgical, small level surgical valves, both having 17 millimeter prosthesis inner diameter. And of course, this needs to be anticipated at the time of first prosthetic implant. And I think as cardiac surgeon, knowing that now and having the experience of previous cases, you will try at the time of your first surgery to use some techniques to avoid any risk of severe mismatch. And as we will do also for transcatheter techniques, we'll try to use prosthesis, avoiding this risk of severe mismatch. And it's true that in the setting of valve-in-valve procedures, so TAVI implanted in a degenerated surgical valve, you can always try to enlarge the effective orifice area by fracturing the surgical valve. But let's say that it's far from being widely validated, especially in the low-risk population. And I think the second group of issues is, of course, and obviously, the risk of coronary obstruction. Again, two examples. Degenerated sapien 3 in a very small sinus of Valsalva, and a degenerated small soaring mitral flow with a very low takeoff, as illustrated on the left of your screen. Again, this has and can be anticipated at the time of first prosthetic implants. And what we have learned and currently are applying at the time of TAVI implantation, if we use that as the first procedure, is now to properly orient the commissures of a transcatheter valve in order to avoid any structural obstruction by the transcatheter valve related to the coronary arteries. And in case it has not been properly anticipated, again, we know that we have some bailouts or advanced or complex techniques that have been described to avoid this risk, both in the setting of surgical prosthesis degenerescence or native valve transcatheter aortic implantation, namely the chimney stent technique implantation and the basilica technique. But again, I think we have to agree that this is far from being validated on large cohorts of patients, and especially not validated in the setting of low-risk patients. So again, this potential issue has to be taken seriously into account at the time of first implantation in a patient with long life expectancy. So I think we can conclude this session that has been very fruitful, very intense in terms of exchange and reflection on this topic. And what I would like to say, maybe to summarize what we have said, is that even though we have a clear validation with a short and mid-term endpoints of TAVI in the low-risk population, it does not mean that we should and we could offer TAVI for all blindly. And of course, and obviously, the heart team has to tailor the therapy based on individual clinical, but even more importantly, anatomical risk assessments. And I think we have underlined that with a crucial role of the CT scan assessment at the time of the initial heart team discussion for all patients. And we, as members of the heart team, both cardiac surgeons, interventional cardiologists, need to schedule the lifelong treatments of those aortic stenosis patients, thinking from first prosthesis implants about reintervention and all the related issues we have discussed, and leading us maybe to adapt our technique and leading us to understand that we need to probably have better techniques to refine our implants and to refine our standards requirements in terms of initial procedural outcomes for the first procedure. So I have now to thank you, both you, Sabine, Thomas, for the time spent to prepare this session, for your active participation, your very fruitful comments coming from the surgical standpoints. That is really important. I want to thank all of our colleagues that were connected and actively participated through the chat with their questions. And hopefully we'll see each other during upcoming future physical meetings, and for sure next PCR webinar events. Thank you and bye-bye.
Thank you, Nicolas. It was a great pleasure.
Thank you so much. Bye-bye.
Bye, Sabine. Bye-bye.